Hello, my name is Raj Shah. I'm a geriatrician here. I'm really excited. Now, in the world I work in as a geriatrician and somebody who does clinical research here at Rush University Medical Center, I spend a lot of time thinking about how we do research that makes a difference. And in many ways, we anticipate or expect our participants, people who volunteer to be part of our research studies, to perform at their best level. But in our system of research, even though it's world-renowned, we don't always give our participants a voice to be part of the process unless we ask them very directed questions and they provide us very directed answers. And as a result, how can we ever expect the people that volunteer and spend their time to find the new discoveries, to answer questions around health and to better health, to be able to figure out the right things to do? We need to find a way to incorporate the patient and to allow their voice to be heard in research. Now, I've spent over a decade in my career here at Rush University Medical Center dedicated to the design and conduct of clinical research to find new treatments, new diagnoses, new ways of preventing common age-related conditions. That work has led me to realize how complex a task it is to do clinical research. There are so many people involved, so many decisions to be made, so many balls up in the air, that I'm always amazed that we can go through the process of completing a research project from the idea and prioritization to the point of getting results that we disseminate. In many ways, I feel that research is as complex as building a jet plane. Now, if I can give you a little bit of a flavor about what a research cycle looks like, essentially it starts with researchers, people curious, people wanting to do the right things to improve the conditions and health and well-being of our population, to find issues that are affecting the health. And then they look for questions. They design questions that will hopefully address those issues that matter. And then they try to prioritize those questions about which ones are the most important. And finally, after prioritizing those questions, they figure out what's in their toolbox to best answer those questions and design a protocol to help find an answer. And after they put this protocol together, they have to secure resources, people, money, energy to be able to actuate that research protocol. And when they secure those resources, they have to go through regulatory processes to make sure that we're doing the research in a safe manner and protecting humans that are part of it. And then we have to spend time to go out into the field, to talk with individuals one-on-one, to tell them about the risks and the benefits and the alternatives of our studies, and to encourage them or engage them enough that they are willing to volunteer to be part of our studies. And then we have to spend a lot of time to keep them in the studies, to make sure we collect high-quality data. And then we have to analyze that data and to put it in a way that people can understand it and that it can be disseminated to the scientific community and to the public. That process takes a long time and takes a lot of energy. And sometimes after 3 or 5 or 10 years of working on a project, I've been in a situation where you come to the end of it and you realize that nobody is using that information in the day-to-day practice of clinical care. So what we've done is we've designed the jet plane and people wanted the train. And as a result of it, I've been spending a lot of time recently thinking about how can we improve our clinical research system. So when people want that train, we build the train. And when they want the jet plane, we build the jet plane. And luckily, I'm not alone in trying to find that answer to make our research system more impactful in people's day-to-day decisions. Over the last 5 to 10 years, there's been an idea that has been popping up. The idea is called patient-centered outcomes research. The hope of patient-centered outcomes research is really to be able to add the voice of the patient so that they can share their experiences and get us better answers. So what are the principles of patient-centered outcomes research? It can be summarized with a phrase that the field has been using for a while. It's the phrase that's on the title of my slide and my presentation. It's nothing about us without us. Essentially what it's saying is that if the end user of the information we learn in our clinical research is people, our people, how do we make sure that people's voices are involved throughout the process in all those steps that I just mentioned so that we can make sure we have the answers for them at the end? Now, there's a promise around and the principles around patient-centered outcomes research. The principles are essentially if we give people a voice in the research process, that they will then have the tools and the capabilities to make better decisions about the health outcomes that matter to them, to be able to analyze and judge what are the right alternatives to maintain their health care and well-being, and to be able to determine what is the best value for their health and health care over time. And the way the promise works is that if we do this right, with this idea around patient-centered outcomes research, that there'll be two big things that will change. First, the questions we ask will change because people, patients, will be involved as stakeholders in defining the questions that matter to them. And what could some of those questions be? It could be questions with my health situation, where I live, who I am, what's going to happen to me? What are going to be the best options for me, for my health and well-being over time? And another question may be, how am I going to get my health system and my providers to advise me in the best way to maintain my health and well-being? And the other benefit of and promise of patient-centered outcomes research is that the engagement of the patient will change over time. In many ways, patients right now are passive users of the data that's filtered through another person that might have more skill to be able to apply and make decisions in their day-to-day life about their health. But with patient-centered outcomes research, more of them might get active and be willing to participate in the studies that are ongoing. And maybe they'll tell their friends and their peers and their family to participate in these studies so we can get answers quicker and more efficiently because they can see the benefit. And maybe some of them will go on and decide they want to review those research protocols before they even start so that we can make sure that it's aligned with the questions that matter for them. And then finally, some of them may go on and decide they want to pool their resources together. And as a patient group with a particular condition or a particular disease, decide to provide an infrastructure to fund the research that would benefit them and their needs and answer the questions that matter. Now, right now, PCOR, or patient-centered outcomes research, is a promise. How do we start turning a promise into reality and into practice? And at the Rush Alzheimer's Disease Center for the last 2 decades, we've been working on ways and iterating on a model to try to help us to incorporate patients in our research on a day-to-day basis. And where does this start? Well, it starts with these 3 intertwining loops. And it starts with a relationship that builds over time where we as faculty and staff involved in research go into the communities around our hospital and essentially talk with community leaders about what are their issues around health. And then we learn from what their needs are in their space and in their place. And we start thinking about the skills and the expertise we have in our center. And then we look for ways to give first. By giving first to the things that are of priority to the community and their leaders, we hope to be building that trust so that we can then go in and ask about them participating and working with us as advocates for research. Now, the new loop in this is the second inner loop, which essentially allows the individuals that want to be part of the research process to be involved from the beginning in how we prioritize questions that matter, how we design our studies, how we end up recruiting individuals to participate, and then how, when we finally get the results we want, that we can have them help us to share those results. And if we do this right, then that final circle will attract more individuals who'd want to take the opportunity to volunteer, to participate in the studies that are ongoing, to be consent to participate, to be retained in studies, to be able to provide the data that's important to them and to us, and then to help us as we learn what that data means, to go back into that outer loop again and share that with their communities by giving back. And when we give back, that opens up the opportunity to evaluate the entire process and brings us the option of then asking new questions. So the cycle is reborn, and we can answer the next level of questions that are affecting people and their communities over time. Now, this model, Engage PC, is something that's going to take some time to implement. It's going to take time, it's going to take energy, it's going to take us building partnerships of trust that last for many years. It's going to mean letting go sometimes and letting somebody else hold the driver's wheel around our research so that they can be part of the discussion and share their voice. But we hope by having participants engage and have their voice in what we are doing, that we will get better answers over time and do better research. So for many people, research means the process of creating generalizable knowledge. But how I like to think about research is dash, and search. And the search is the effort that we do together as people interested in the health and as trained as professionals to help people to age well and to maintain their abilities for as long as possible, to work with individuals that might be wondering about how they can age better and maintain ability maximizing lives. And we work together and search together to find new paths, that essentially reduce suffering and alleviate fear. And if we do this right, the part means that it's repeated, it's continuous. The search always happens. So it's almost like the situation where you might leave your cell phone on a table, walk away, come back 5 minutes later, not see your cell phone at the table, go back, come back 30 minutes later and find your cell phone on the table. The answers to some of our most complex health problems are within us, nowhere else. And if we research, relook, reevaluate, and work together, we will find some of these solutions. And as we do this, if we open up the space to allow for people's voices to be part of this, where they can say, aha, I learned something that mattered, and allow them to share it, we will be better off. Nothing about us without us. I appreciate the opportunity today to share my voice with you. I hope that you will get a chance to share your voices with others. And I hope as you talk with your friends and your family and your peers, that you will let them know that their voices are needed in clinical research to find the answers that matter. Nothing about us without us. Thank you.